Welcome back to Bookfulness. This is episode 2 in our deep dive into Moore's Clinically Oriented Anatomy, ninth edition.
Hello again. Yeah, in our first session, we really laid down the anatomical alphabet, the planes, positions, and we built the body's framework.
Yeah.
The skin, the bones, everything that contains and supports.
We definitely set the stage, and now we're moving into the dynamic parts, what makes the body do things.
Right.
We're going beyond that static structure to the systems for action, transport, and control. So today it's the muscular, cardiovascular, lymphoid, and nervous systems. We're looking at pages 131 to 178 in chapter 1.
And this is where I think the clinically oriented part of the title really starts to shine.
Yeah.
Because for anyone going into healthcare, well, just memorizing names of muscles or bones isn't enough, is it?
Not at all.
You have to grasp the function, how these systems work normally, how they react under stress, and crucially, how a problem in one system shows up as a symptom somewhere else. We're shifting from just structure to, well, mechanism.
Yeah.
Dynamic physiology.
Okay, let's jump right in with the system for movement, the muscular system. The text kicks off by outlining 3 basic types of muscle tissue. Table 1.1 gives a great summary of their differences.
Yeah, 3 very distinct types doing different jobs. First up is skeletal striated muscle. This is the stuff you control consciously.
Our voluntary muscles.
Exactly. Think biceps, quads, all of those. It's known for strong, rapid contractions.
Yeah.
And striated just refers to that striped look you see under a microscope, which comes from how the contractile proteins are arranged. Very organized.
Then there's cardiac striated muscle. It looks similar, striped, but the control is totally different.
Right. It's involuntary. You find it only in the heart wall, the myocardium, and just a little bit extending into the walls of the big vessels connected to the heart, like the aorta and pulmonary vein.
And that involuntary control is fascinating. It's not directly run by your conscious thought.
No, the heart has its own internal pacemaker system, a specialized conducting system that sets the basic rhythm. The autonomic nervous system, which we'll get to later, can speed it up or slow it down, adjust the force, but the fundamental beat comes from within the heart itself. It just has to keep going.
Okay, and the third type is smooth muscle. The name kind of gives it away.
It does. No stripes, no striations. It's also involuntary. This is more the infrastructure muscle. It makes up the walls of blood vessels, that middle layer, the tunica media, and the walls of hollow organs.
Like the digestive tract.
Exactly. The gut, the bladder, airways, ducts. All lined with smooth muscle to push things along or control diameter. But it also shows up in places you might not expect, like those tiny erector muscles attached to hair follicles that make your hair stand on end.
Goosebumps.
That's smooth muscle. And also in the eye, controlling your pupil size and lens shape. So it's quite versatile, just operates behind the scenes.
So focusing back on skeletal muscle, the ones we see and feel, they have the main contractile part, the belly, which is usually reddish and fleshy. And then they attach to bones via these white, tough, non-contractile bits, tendons or aponeuroses.
Right. Tendons are the cord-like structures, like your Achilles tendon. Aponeuroses are broad, flat sheets of tendon, common in the abdominal wall, for example.
And the shape, the architecture of that muscle belly is really important for its function, isn't it? Figure 1.18 shows a few different types.
Absolutely. Form dictates function here. A flat muscle might blend into an aponeurosis. A fusiform muscle, like the biceps, is spindle-shaped, thick in the middle, tapering at the ends. Good for range of motion and force.
Then you have things like pennate muscles. They look like feathers.
Yeah, the fibers attach obliquely, like the barbs of a feather, onto a central tendon. This packs more fibers into a smaller space, so they're often very powerful, even if the range of motion is less. Think deltoid or rectus femoris.
And convergent muscles.
They start broad and narrow down to a single tendon, like pectoralis major. Allows force to be directed to a specific point. Then you have simpler shapes, like quadrate, squarish, circular sphincters, or muscles with multiple heads or bellies, like the biceps or triceps.
Knowing these shapes, plus the naming conventions often based on location or shape, size, attachments, action, it gives you a lot of clues about what the muscle does without even seeing it move.
It really does. It's anatomical shorthand.
Now, when we talk about how a muscle works, the classic terms are origin and insertion. Origin is usually proximal, the fixed point. Insertion is distal, the moving part.
That's a traditional definition, and it works, sometimes. But the book rightly points out it can be misleading. Muscles don't care about definitions. They just pull.
What do you mean?
We'll take your biceps again. When you lift a cup, your forearm insertion moves towards your upper arm origin. That fits the definition. But what about a pull-up?
Ah, okay. Your hands are fixed on the bar, that's the distal part. and your body, the proximal part, moves towards your hands. The origin is moving towards the insertion.
Precisely. The roles reverse, depending on which end is stabilized. So, while origin and insertion are useful starting points, for clinical accuracy, especially in biomechanics, it's often better to just talk about the proximal and distal attachments, or medial and lateral attachments. It avoids ambiguity.
That makes sense. It depends on the context of the movement. Okay, let's talk about the types of muscle contraction. The book outlines 3 main ways skeletal muscles activate: reflexive, tonic, and phasic.
Yeah, and we need all 3 happening constantly. Reflexive contraction is automatic. Think about your diaphragm contracting when you breathe normally. You're not consciously telling it to fire each time.
Or the knee-jerk reflex.
Perfect example. That's a purely reflexive skeletal muscle contraction, triggered by stretching the tendon.
Then there's tonic contraction, or muscle tone. This isn't about movement, right? It's more subtle.
Exactly. It's a slight, constant tension that almost all healthy muscles maintain even when they're at rest. It doesn't produce movement, but it keeps the muscle firm, ready to respond, and critically, it stabilizes joints and helps maintain posture.
So it's like the engine idling.
That's a great analogy. It's that background hum.
Yeah.
And you really notice its importance when it's gone, like under general anesthesia or in paralysis. Joints become unstable, floppy, because that baseline stabilizing tension is lost. A paralyzed limb might assume an odd position simply because the tone is gone.
Interesting. Okay, and the third type is phasic contraction. This is the one we usually think of active muscle work.
Right. This is when the muscle actively contracts to produce movement or resist a force. And phasic contractions are divided into 2 main types: isotonic and isometric.
Okay, break those down.
Isometric means same measure or same length. The muscle generates tension, but it doesn't shorten or lengthen, so no movement occurs at the joint. Think pushing against an immovable wall or just holding a heavy object steady.
You feel the strain, but nothing's moving.
Exactly. Isotonic, on the other hand, means same tension, though that's a bit of a misnomer. The tension can fluctuate. But the key is that the muscle changes length and movement occurs.
And isotonic contraction itself has 2 subtypes, which figure 1.20 illustrates really well. This seems important.
It is absolutely fundamental. We have concentric contraction and aggressive contraction.
Concentric is the shortening.
Yes. Concentric is when the muscle generates force and overcomes resistance, causing muscle to shorten. This is your classic lifting action, curling a dumbbell, standing up from a chair.
And eccentric.
Eccentric is when the muscle is active, generating tension, but it's lengthening because the external force is greater than the force the muscle is producing. It's a controlled yielding or braking action.
So lowering the dumbbell slowly or sitting down gently into the chair?
Precisely. You're actively controlling the descent against gravity, using the same muscles that lifted you up, but now they're lengthening.
Why is making this distinction between shortening and controlled lengthening so vital?
Several reasons. First, coordination. Almost all smooth, coordinated movements involve a mix of concentric and eccentric contractions. Walking, running, throwing, they all rely on eccentric braking. Second, force production. Eccentric contractions can actually generate more tension, up to 50% more than maximal concentric contractions.
Wow, really? So you're stronger lowering a weight than lifting it?
Potentially, yes. In terms of the tension the muscle can withstand and control eccentrically. This is why eccentric training is so effective for building strength and resilience. It's also why muscles are often injured doing eccentric actions. They're handling very high forces while lengthening.
That leads into the next section about muscle function and how muscles work together. It's not just one muscle doing everything.
Never. Movement is always a team effort. The book describes 4 main functional roles.
Okay, what are they?
First, the prime mover, or agonist. This is the main muscle or group of muscles responsible for producing a specific movement. It contracts concentrically.
Like the biceps during an arm curl.
Exactly. Then you have the fixator. Fixators contract isometrically. They don't produce movement themselves, but they stabilize the origin of the prime mover, or stabilize a body part, so the prime mover can work efficiently.
So like the muscles around your shoulder blade holding it steady while your arm moves?
Perfect example. Without those fixators, the force from your arm muscles would just wiggle your shoulder blade around instead of moving your arm effectively.
Okay, third role.
The synergist. Synergists help the prime mover. They might contribute a bit to the same movement, or they might cancel out an unwanted secondary action of the prime mover. For instance, some wrist muscles act as synergists during fist clenching to prevent the wrist from bending at the same time.
They fine-tune the movement.
Yeah, or stabilize an intermediate joint if the prime mover crosses more than one joint.
And the last one is the antagonist.
The antagonist is the muscle that opposes the action of the prime mover. When the prime mover contracts concentrically, the antagonist typically relaxes progressively, but often it also contracts eccentrically to control the speed and smoothness of the movement, acting as a brake.
Like the triceps during that biceps curl, controlling how fast you flex your elbow.
Precisely. Agonist and antagonist pairs work together constantly.
The text mentions shunt versus spurt muscles. Are these distinct types or related to these roles?
They relate more to the mechanics of how a muscle attaches and pulls, which influences its primary role. It's about leverage. A spurt muscle attaches further away from the joint it moves,
Giving it better leverage for rotation.
Exactly. Its line of pull creates a strong turning force. These are often your prime movers. A shunt muscle attaches very close to the joint. Its line of pull is more parallel to the bone it's moving.
So it's pulling along the bone towards the joint.
Right. This means it's very effective at stabilizing the joint, pulling the bones together, and resisting dislocation forces. Shunt muscles are often important fixators. Many muscles, like the brachialis in the arm, effectively act as both, contributing to movement and stability. It's about the geometry of the attachment.
Okay, that clarifies things. Now, how do these muscles get their instructions and fuel? Neurovascular supply. The book highlights a key difference between nerve and artery supply.
Yeah, this is a really practical point. Nerve supply to muscles is remarkably consistent. Generally, muscles in the same functional compartment doing similar jobs are innervated by the same nerve or nerves.
Makes learning them easier.
It does. You learn the nerve, you know the muscles it controls. Also, crucially, motor nerves tend to enter the muscle on its deep surface, in the fleshy part, away from harm. It's a protective design.
But the blood supply, the arteries, are less predictable.
Much less predictable. Arterial supply is often from multiple sources, and the specific arteries involved can vary quite a bit between individuals. You generally figure out which artery supplies a muscle based on proximity. Whatever major artery runs nearby is likely sending branches to it.
So less strict rules for arteries.
Fewer strict rules, more redundancy often. This variability sometimes allows surgeons to tie off an artery without killing the muscle, because other arteries might provide enough collateral flow. We'll touch on that more with the cardiovascular system.
All right, let's hit the clinical correlates for skeletal muscles, pages 140, 142. First up is muscle testing.
Essential clinical skill. It's how you assess the integrity of the nerve supply to a muscle. You typically ask the patient to perform the muscle's action against your resistance, or you try to move their limb while asking them to resist.
And you're grading the strength.
Exactly. You grade the power, usually on a standard scale. Weakness in a specific muscle or group points towards a potential nerve lesion at a particular level.
And if there is nerve damage leading to muscle dysfunction and paralysis,
then you see atrophy, the muscle wastes away. This can happen from disuse, like being in a cast, but denervation, atrophy, loss of nerve supply, is particularly severe.
and this goes back to the idea of thinking about loss of function.
Yes. Don't just think biceps flexes elbow. Think, if the nerve to the biceps is cut, the patient cannot strongly flex their elbow, and the elbow might hang in a slightly extended position at rest. Why?
Because the antagonist, the triceps, still has its normal muscle tone.
Precisely. The unopposed tonic pull of the healthy antagonist muscle pulls the joint into an abnormal resting posture. This is a key diagnostic clue. Loss of function and change in resting position due to loss of tone.
Okay, what about common injuries like muscle soreness or a pulled muscle? Figure B1.8 shows a hamstring tear. Why are muscles vulnerable to this?
It comes down to physics and biology. Muscle fibers have a limit to how far they can stretch. They can't safely elongate much beyond about 1/3 of their resting length. Usually, your joints and ligaments stop you before you reach that point.
But not always.
Not always, especially with muscles that cross two joints, like the hamstrings. They cross both the hip and the knee. If you try to touch your toes with your knees straight, you're maximally lengthening the hamstrings at both ends.
I can feel that.
Right. Now imagine doing that forcefully or quickly, especially during an eccentric contraction where the muscle is already under high tension trying to control movement like sprinting or landing from a jump. The forces can exceed the tissue's limit, causing fibers to tear. That's your pulled muscle or strain. Hamstrings are notorious for this.
Ouch. Okay, last clinical point here. Muscle growth and regeneration. When bodybuilders get huge, are they making new muscle cells?
No, not really. Skeletal muscle fibers themselves don't divide. The increase in muscle size from exercise is hypertrophy. The existing individual muscle fibers get bigger, thicker, by adding more contractile proteins, myofibrils, inside.
So bigger cells, not more cells.
Correct. There are some precursor cells, called satellite cells, nestled alongside the muscle fibers that can help with minor repair and limited regeneration, but they can't replace large amounts of damaged muscle. Significant injury usually results in fibrous scar tissue forming, which isn't contractile.
So skeletal muscle is good at getting bigger, but not great at repairing major damage.
That's a fair summary.
All right, let's quickly revisit the other muscle types before moving to transport systems. Cardiac muscle.
Right, the heart muscle. Clinically, a key concept is its incredible metabolic demand. It never stops working, so it needs a constant, rich blood supply, about twice as much blood flow per gram as active skeletal muscle.
Which is why blockages in coronary arteries are so dangerous, leading to myocardial infarction, heart attack, tissue death.
Exactly. The heart muscle can also undergo hypertrophy, getting thicker in response to chronic high pressure, like hypertension. But like skeletal muscle, the cells can't divide, so there's a limit to this compensation.
And smooth muscle, what's key clinically there?
The big difference is its regenerative capacity. Smooth muscle cells can undergo hyperplasia, meaning they can divide and increase in number. They also undergo hypertrophy.
So they can adapt more.
Yes. Think about the uterus. During pregnancy, it grows massively through both hypertrophy and hyperplasia of its smooth muscle layers, or blood vessels thickening their walls in response to chronic high blood pressure. This ability to increase both cell size and cell number gives smooth muscle tissues greater adaptive potential than striated muscle.
Got it. Okay, let's shift gears now to the transport highways. The cardiovascular system, pages 144 to 154. Figure 1.22 gives that nice overview of the two circuits.
Yeah, the two-pump system. The right side of the heart pumps blood low in oxygen to the lungs as the pulmonary circulation gets oxygenated there.
Then it comes back to the left side,
which pumps the freshly oxygenated blood out to the rest of the body, the systemic circulation.
And figure 1.22c makes a really important point. The systemic circulation isn't just one big loop after the lungs.
No, that's crucial. It branches into many parallel circuits. Blood goes simultaneously to the brain, the kidneys, the gut, the limbs, each through its own dedicated arterial branches off the main trunk, the aorta.
Why is that parallel setup important?
It allows for independent regulation of blood flow. Your body can send more blood to your digestive system after a meal without necessarily starving your brain, or direct more flow to your muscles during exercise. If it were all one series circuit, flow changes in one area would affect everything downstream.
Makes sense. Okay, the vessels themselves, arteries, veins, capillaries, most have that three-layer wall structure, the tunics, shown in figure 1.23.
Right. Innermost is the tunica intima, a thin layer of endothelial cells lining the lumen, plus a bit of connective tissue. Very smooth surface for blood flow. Capillaries are basically just this layer.
Middle layer.
Tunica media. This is mainly smooth muscle and elastic fibers. It's the thickest layer in arteries and the most variable layer overall. Contraction or relaxation of this smooth muscle changes the vessel diameter, controlling blood flow and pressure.
And the outer layer.
Tunica adventitia. This is the tough outer connective tissue coat. It anchors a vessel and contains nerves and, in larger vessels, tiny blood vessels, vasa vasorum, that supply the wall itself.
And the main difference between arteries and veins is the thickness of these layers, especially the media.
Generally, yes. Arteries handle high pressure, so they have thicker, more muscular and elastic walls than veins. Veins handle low pressure, so their walls are thinner, and their lumens, the internal channel, are often wider.
Looking closer at arteries, figure 1.24, they range from huge elastic ones near the heart to tiny arterioles.
Exactly. Large elastic arteries, like the aorta, absorb the pressure pulse from the heartbeat, smoothing out blood flow. Medium muscular arteries distribute blood to different body regions. Their thick tunica media allows them to actively regulate flow. Small arteries and arterioles are the main resistance vessels, controlling blood pressure and flow into the capillary beds where exchange happens.
A key concept for arteries is redundancy backup routes, collateral circulation.
Very important. This refers to alternative pathways, or anastomosis, where branches of different arteries connect. If one pathway gets slowly blocked, these connections can enlarge over time and provide blood flow around the blockage.
Like detours on a highway.
Good analogy. They're especially common around joints, where movement might temporarily pinch off a main artery.
But you mentioned slowly blocked. What if it's sudden?
That's the catch. These collateral pathways need time, days or weeks, to enlarge enough to handle the full blood flow. If a major artery is blocked suddenly, like by a blood clot, embolus, the existing collaterals are usually too small to compensate immediately. That leads to ischemia, lack of blood flow, and potentially infarction tissue death.
Which brings us to terminal arteries.
Right. Some arteries have no significant anastomosis. These are true terminal arteries. Block one, and the tissue it supplies will die. The artery supplying the retina is a classic example.
Blindness if it's blocked.
Instantly. Then there are functional terminal arteries. These might have tiny anastomoses, but they're insufficient to prevent infarction if the main artery is blocked suddenly. This applies to critical areas like segments of the heart, brain, kidneys, liver, and spleen. Blockage here is still usually catastrophic.
Okay, switching to the veins, they're generally more numerous and variable than arteries.
Yes, and they hold a lot more blood, maybe 80% of your total blood volume at rest. They're the capacitance vessels. Because the pressure is low, especially in the limbs fighting gravity, they need help getting blood back to the heart.
That's where venous valves come in.
Absolutely crucial in medium veins, particularly in the limbs. They're passive flaps, cusps of the tunica intima, that break the column of blood into segments and ensure flow only goes towards the heart. They prevent backflow.
We also often see veins traveling right alongside arteries, especially deep in the limbs. Vena combatantes, figure 1.25.
Yes, accompanying veins. Often paired, sometimes more, wrapped in the same connective tissue sheath as the artery. This close proximity is key for the musculovenous pump.
Ah, the mechanism that helps push blood uphill? How does that work?
It's elegant. You have these deep veins nestled amongst skeletal muscles. These muscles are contained within compartments defined by tough, inelastic, deep fascia.
Like wearing tight compression socks, but built in.
Kind of. When you contract those muscles, like walking or clenching your calf, the muscles bulge but can't expand outwards much because of the fascia. So they squeeze the deep veins running between them.
Milking the blood upwards.
Exactly. And the venous valves prevent it from falling back down when the muscles relax. It's incredibly effective. That's why moving around is so important for circulation, especially preventing clots in the legs. If you stand still for too long, the pump isn't working and blood pools.
And briefly, capillaries, the exchange sites.
Tiny, thin-walled vessels, just the tunica endothelium. Their walls are permeable, allowing oxygen, nutrients, waste products, hormones, etc., to exchange between the blood and the surrounding tissue fluid, interstitial fluid. They form vast networks called capillary beds.
Okay, clinical issues here. Arteriosclerosis is the general hardening of arteries.
Right, loss of elasticity. The most common and important form is atherosclerosis, shown in figure B1.9. This is where fatty plaques atheromas build up within the tunica intima.
What's the danger there?
Two main problems. The plaque narrows the lumen, restricting blood flow and increasing pressure. More critically, the plaque surface is rough and prone to ulceration, which can trigger formation of a blood clot, thrombus right there, potentially blocking the vessel completely. Or a piece of the plaque or clot can break off and travel downstream, embolus, and block a smaller vessel.
Leading to ischemia and infarction, heart attack, stroke, gangrene in limbs.
Exactly. And for veins, the common clinical issue is varicose veins, figure B1.0. This happens when the venous valves fail, usually in superficial veins where there's less external support. Blood flows backward, reflexes, and pools, causing the veins to become dilated, tortuous, and elongated. It's often cosmetic, but can lead to pain, swelling, and skin changes due to chronic venous insufficiency, failure of those one-way valves.
Okay, moving from blood transport to fluid drainage and defense. The lymphoid system, pages 154, 159. What's its main job?
Its primary role is collecting the excess fluid, proteins, and other stuff that leaks out of blood capillaries into the tissue spaces. This fluid is called lymphs, and returning it to the bloodstream. It's like a parallel drainage system, essential for fluid balance.
And it has other roles too.
Yes, it's crucial for absorbing digested fats from the intestine, which are too large to enter blood capillaries directly, and transporting them to the blood. And critically, it's a major part of the immune system.
What are the components? Figure 1.27 shows the overall layout.
It starts with blind-ended lymphatic plexuses, capillary networks, in the tissues. These drain into larger lymphatic vessels. Along the way, these vessels pass through lymph nodes, small bean-shaped structures packed with lymphocytes and other immune cells.
The nodes act as filters.
Exactly. They filter the lymph, trapping pathogens, cell debris, and even cancer cells. The filtered lymph continues through larger vessels and eventually drains back into the large veins near the heart. There are also specialized lymphoid organs like the spleen, thymus, tonsils.
Where does all this lymph fluid end up?
Most of it from both legs, the abdomen, the left chest, left arm, and left side of the head and neck, collects into the largest lymphatic vessel, the thoracic duct. This big duct ascends through the thorax and empties into the venous system at the junction of the left internal jugular and left subclavian veins, the left venous angle.
Only the upper right part of the body drains differently.
Right. The right arm, right chest, and right side of the head and neck drain via a smaller right lymphatic duct into the right venous angle. Knowing these drainage territories is vital for understanding how infections or cancers might spread.
Which brings us straight to the clinical relevance, especially metastasis, the spread of cancer, pages 157 to 159.
Hugely important. Lymphatic vessels are the most common initial pathway for the spread of carcinomas, which are cancers arising from epithelial tissues like skin, glands, lining of organs. Cancer cells can break off the primary tumor, invade nearby lymphatic vessels, get carried along with the lymph flow, and then get trapped in the first lymph node they encounter.
And that node becomes a secondary tumor site.
Yes, potentially. This is why surgeons often remove or biopsy regional lymph nodes, sentinel nodes, when treating carcinomas to check if the cancer has started to spread.
What about other cancer types like sarcomas?
Sarcomas cancers of connective tissues like bone or muscle behave differently. They tend to spread via the blood, particularly the veins. This is called hematogenous spread.
Why veins?
Veins are more numerous, have thinner walls, and lower pressure than arteries, making them easier for cancer cells to invade. Venous blood from most of the body eventually flows through the liver and the lungs.
So the liver and lungs are common sites for secondary sarcoma tumors?
Very common. Understanding these different patterns of spread lymphatic for carcinomas, hematogenous for sarcomas, is fundamental to cancer staging and treatment planning. The text also mentions lymphangitis, inflammation of lymph vessels, often seen as red streaks under the skin during infection, and lymphedema, swelling due to impaired lymphatic drainage.
Okay, powerful systems for transport and defense. Now, let's move to the ultimate control network. The nervous system, starting on page 159. Big topic.
Huge. We break it down structurally and functionally. Structurally, you have the central nervous system, CNS, the brain and spinal cord, the integration and command center, and the peripheral nervous system, PNS, everything else.
Right.
The nerves connecting the CNS to the rest of the body, plus associated ganglia.
And functionally?
Functionally, we divide it into the somatic nervous system, which handles voluntary control of skeletal muscles and conscious sensory perception, touch, pain, temperature, etc. And the autonomic nervous system, ANS, which manages involuntary functions, smooth muscle, cardiac muscle, glands. Think digestion, heart rate, sweating.
The basic cells are neurons and neuroglia.
Right. Neurons, figure 1.28, are the communication specialists. You have different types, like multipolar motor neurons carrying commands out from the CNS, and pseudo-unipolar sensory neurons bringing information in. They communicate chemically across junctions called synapses, figure 1.29.
And the neuroglia?
Glial cells. These are the support staff non-neuronal cells that outnumber neurons. They provide physical support, insulation, myelin, nourishment, defense, and maintain the chemical environment for the neurons. Essential, but not directly involved in transmitting the signals over long distances.
Inside the CNS brain and spinal cord, we use specific terms for structures.
Yes. A collection of neuron cell bodies within the CNS is called a nucleus. A bundle of nerve fibers, axons, connecting different nuclei within the CNS is called a tract.
And the tissue itself looks different, gray and white matter, figures 1.3, 1.31.
Correct. Gray matter is where the neuron cell bodies, dendrites, unmyelinated axons, and synapses are concentrated. It's the processing occurs. In the spinal cord, it's deep in an H shape. In the brain, it's mostly on the surface, cerebral cortex, and in deep nuclei. White matter consists primarily of myelinated axons, those tracks we mentioned. The fatty myelin sheath gives it the white appearance. It's the wiring transmitting signals between gray matter areas.
Okay, now moving out to the PNS, what are the equivalent terms?
A collection of neuron cell bodies outside the CNS is called a ganglion, plural, ganglia. And a bundle of nerve fibers, axons outside the CNS, is simply called a nerve.
And nerves need protection, especially as they run through limbs that move. The book uses that telephone cable analogy for the connective tissue layers, figures 1.32, 1.33.
It's a great analogy. Each individual nerve fiber, axon, possibly with its myelin sheath, is wrapped in a delicate layer called the endoneurium.
Like the insulation on a single wire.
Exactly. Then, groups of these fibers are bundled together into fascicles, and each fascicle is wrapped in a tougher, denser layer called the perineurium. This layer is really important. It acts as a barrier, controlling what substances can reach the nerve fibers.
Kind of like the sheath around a bundle of wires inside the main cable.
Perfect. And finally, the entire nerve, all the fascicles bundled together, along with blood vessels supplying the nerve, is encased in the thick, tough outer layer, the epineurium. This provides structural integrity and cushioning. These layers give nerves their tensile strength and resilience.
All right, structure of a nerve sorted.
Yeah.
How is the PNS organized overall? We have cranial nerves and spinal nerves.
Right. Cranial nerves emerge from the brain, 12 pairs. Spinal nerves emerge from the spinal cord, 31 pairs. Each spinal nerve, figure 1.34, is formed by the union of two roots attaching to the spinal cord. A posterior dorsal root, which carries sensory information in, and has a ganglion, the spinal ganglion or dorsal root ganglion, containing the sensory neuron cell bodies, and an anterior ventral root, which carries motor commands out.
Sensory in the back, motor in the front.
Generally speaking, yes. These two roots join just outside the spinal column to form the mixed spinal nerve, carrying both sensory and motor fibers.
This spinal nerve setup leads to the concept of segmental innervation, dermatomes, and myotomes.
Absolutely key for clinical diagnosis, because each spinal nerve develops in association with a specific body segment, such as during embryonic development, figure 1.35, it retains a connection to that segment. A dermatome, figure 1.36, is the specific area of skin supplied by the sensory fibers from a single spinal nerve.
So numbness or tingling in a specific pattern on the skin can point you to which spinal nerve or cord level is affected.
Precisely. The dermatome map is a clinical roadmap. The motor equivalent is the myotome. That's the group of muscles primarily innervated by the motor fibers from a single spinal nerve root or spinal cord segment. Testing muscle strength in different groups helps pinpoint motor nerve lesions.
Okay, so the spinal nerve forms carry sensory and motor info for its segment. Then what happens? It splits again.
Yes. Almost immediately after exiting the intervertebral foramen, the spinal nerve divides into two main branches, or ramus, figures 1.37 to 1.4. There's a smaller posterior dorsal ramus and a much larger anterior ventral ramus.
Do they supply different areas?
Completely different territories. The posterior rami turn backwards and supply only a narrow strip. The deep intrinsic muscles of the back, the joints of the vertebral column, and the skin directly overlying them. They follow a simple segmental pattern down the back.
And the larger anterior rami?
They supply everything else, the muscles and skin of the limbs, and the anterior and lateral trunk. In the thoracic region, T2, T11, 12, they mostly remain segmental too, running between the ribs as the intercostal nerves.
But elsewhere, they do something more complicated.
Yes. In the cervical, lumbar, and sacral regions, the anterior rami don't stay separate. They merge, braid together, exchange fibers, and form complex networks called plexuses, like the brachial plexus for the arm or the lumbosacral plexus for the leg.
Why form these tangled plexuses?
It allows nerve fibers originating from multiple spinal cord segments to combine and be redistributed into new peripheral nerves that supply specific parts of the limb. It means that most limb muscles receive innervation from more than one spinal segment, and most peripheral nerves contain fibers from multiple segments.
So damage to a single spinal nerve root doesn't completely paralyze a limb muscle?
Usually not completely, no. It provides redundancy and ensures coordinated innervation of complex limb structures. It's a clever bit of wiring.
Okay, one more layer of classification. The type of information the nerve fibers carry. Somatic versus visceral, figures 1.41, 1.42.
Right. We can categorize fibers based on what they connect to and the type of information. 1. General sensory fibers, general somatic afferent GSA, carry touch, pain, temperature, pressure, proprioception, sense of position, from skin, muscles, tendons, joints, conscious sensation. 2. Somatic motor fibers, general somatic afferent GSE, carry commands to skeletal muscles, voluntary movement. 3. Visceral sensory fibers, general visceral afferent GVA, carry sensory information from internal organs, glands, blood vessels, mostly subconscious, like blood pressure monitoring, but can include visceral pain like cramps or angina, often poorly localized or referred. 4. Visceral motor fibers, general visceral efferent GVE. These are the fibers of the autonomic nervous system. They carry commands to smooth muscle, cardiac muscle, and glands. Involuntary control.
Understanding these fiber types within a given nerve helps predict the effects of nerve damage.
Absolutely. A nerve lesion might affect only motor function, only sensation, or a combination, depending on the fibers involved.
Okay, let's dive into that last category, the visceral motor system, aka the autonomic nervous system, ANS. Pages 170, 178. You said this controls involuntary stuff.
Right. Heart rate, digestion, sweating, pupil-size all the automatic background processes. The most fundamental difference between how the ANS controls its targets and how the somatic system controls skeletal muscle is the two-neuron chain, figure 1.42.
Explain that. Somatic motor is just one neuron from CNS to muscle.
Yes. A single motor neuron sits in the spinal cord or brainstem. Its axon travels all the way out in a nerve and synapses directly onto the skeletal muscle fiber. Simple, direct connection.
But the ANS uses two.
Always two neurons in sequence to get the message from the CNS to the target organ, smooth muscle, cardiac muscle, or gland. Neuron #1 is the presynaptic or preganglionic neuron. Its cell body is in the gray matter of the CNS, brainstem or spinal cord. Its axon leaves the CNS.
But doesn't reach the target.
No. It travels out to an autonomic ganglion, one of those collections of nerve cell bodies outside the CNS, and synapses there onto neuron #2.
And neuron #2 is?
Neuron #2 is the postsynaptic or postganglionic neuron. Its cell body is in that autonomic ganglion. Its axon then travels the rest of the way to the actual effector organ, heart, gut wall, sweat gland, etc., and synapses there.
So CNS, presynaptic neuron, autonomic ganglion, postsynaptic neuron, target organ. That two-step relay is universal for the ANS.
Universal. Now, the ANS itself has two main divisions that often have opposing effects: sympathetic and parasympathetic. Let's tackle the sympathetic division first. It's often called the thoracolumbar division.
Why thoracolumbar?
Because the cell bodies of all the presynaptic sympathetic neurons are located only in the spinal cord segments between T1 and L2 or L3. That specific region, the intermediolateral cell columns, IMLs, of the thoracic and upper lumbar cord, is the sole origin for the entire sympathetic outflow.
That seems very limited. How does it manage to affect the whole body, head, feet, everything?
Through clever distribution and amplification. First, the axons of these presynaptic neurons leave the spinal cord via the anterior roots and enter the sympathetic trunks, or chains. These are two chains of interconnected ganglia running vertically along either side of the vertebral column, extending all the way up the neck and down into the pelvis.
So the presynaptic fibers travel to these trunks. Then what?
Once a presynaptic fiber enters the sympathetic trunk via a connecting branch called the white ramus communicans, it has several options, which explains the wide distribution. 1, it can synapse immediately with a postsynaptic neuron in the ganglion at that same level. 2, it can ascend or descend within the trunk to synapse in a ganglion at a higher or lower level. This allows T1 fibers to ultimately control structures in the head and L2 fibers to control structures in the feet. 3, it can pass straight through the sympathetic trunk ganglion without synapsing. These fibers form splanchnic nerves that travel to synapse later in peripheral ganglia located out in the abdomen and pelvis, near the major arteries supplying the gut and pelvic organs. These control viscera. 4, rarely some pass through both sets of ganglia to directly stimulate the adrenal medulla, causing hormone-release adrenaline.
Okay, so the presynaptic fibers can travel up, down, or straight through the trunk ganglia. But how did the postsynaptic fibers, the ones starting in the trunk ganglia, get out to places like sweat glands in the skin or blood vessels in the limbs? They need to join the regular spinal nerves, right?
Exactly. And they do this via another set of connecting branches called gray rami communicantes. These connect the sympathetic trunk ganglia back to the spinal nerves. Critically, gray rami connect to all 31 pairs of spinal nerves.
Ah, so every spinal nerve receives postsynaptic sympathetic fibers.
Yes. Those postsynaptic fibers then travel out within both the anterior and posterior rami of the spinal nerves, distributing sympathetic innervation to blood vessels, vasoconstriction, sweat glands, sweating, and erector pili muscles, goosebumps, throughout the entire body, wall, and limbs.
That's the key to its widespread reach. Centralized origin, T1, L2, distribution up and down the trunks, and then hopping onto all spinal nerves via gray rami.
You got it. Plus, there's that neural proliferation or divergence. The text mentions one presynaptic fiber often synapses with 30 or more postsynaptic neurons. This allows for a very diffuse, widespread response. The classic fight-or-flight response activates many systems simultaneously.
Makes sense. So if sympathetic is T1, L2 origin, widespread fight or flight, what about the parasympathetic division?
The parasympathetic is the rest and digest system. Its origin is craniosacral.
Meaning?
The presynaptic neuron cell bodies are located in only two places: specific nuclei in the brainstem, associated with cranial nerves the 3rd, 7, 9, and especially X, the vagus nerve, and in the gray matter of the sacral spinal cord segments, S2, S3, and S4.
So head and tail end, skipping the middle, thorax, and lumbar regions.
Exactly, and its anatomical setup is very different, leading to a different kind of control. It still uses the two-neuron chain, but the presynaptic fibers are very long.
They travel further.
Much further. The presynaptic parasympathetic fiber travels almost all the way to the target organ it's going to control. The synapse with the postsynaptic neuron occurs in a tiny terminal ganglion located either right on the surface of the target organ or actually embedded within its wall.
So the postsynaptic neuron is really short.
Very short, just innervating the local tissue within that organ.
What's the functional consequence of having the synapse right at the target?
It means parasympathetic control is much more discrete and localized. You can activate digestion in the stomach via the vagus nerve without necessarily slowing the heart rate significantly, or constrict the pupil without affecting bladder function. There's very little divergence, usually a 1-to-1 or 1-to-few ratio between pre- and postsynaptic neurons.
So sympathetic, thoracolumbar origin, short preganglionic, long postganglionic fibers synapsing in trunk or prevertebral ganglia, widespread diffuse action via gray rami to all spinal nerves, parasympathetic, craniosacral origin, long preganglionic, short postganglionic fibers, synapsing in terminal ganglia near and target organs, localized discrete action.
That's the perfect summary of the anatomical basis for their different functions.
Fantastic. We've covered an immense amount of ground today, from how muscles contract to how the whole system is wired for transport and communication. Let's try to boil down the absolute must-know takeaways.
Okay. For movement, remember the functional muscle roles: agonist, fixator, synergist, antagonist. And critically, appreciate the difference between concentric, shortening, and eccentric, controlled lengthening contractions. Eccentric is vital for control, shock absorption, and generates high tension.
For transport, think redundancy and critical points. Arterial collateral circulation offers backups, but needs time. Terminal arteries, true or functional, leave no room for error if blocked acutely. And the musculovenous pump is that clever mechanical system using muscle contraction, fascia, and valves to drive venous return.
And for communication, structure enables function. Nerves are protected by layers: endo, peri, epineurium. The ANS operates via that two-neuron chain. The sympathetic system achieves its vast reach via the T1-L2 origin, sympathetic trunks, and gray rami, distributing fibers to all spinal nerves for diffuse control. The parasympathetic uses its craniosacral origin and terminal ganglia for targeted, localized effects.
As we move forward into specific body regions and mores, this systemic foundation is going to be what you constantly refer back to.
Absolutely. And perhaps the final thought to leave you with is about applying this knowledge clinically. It requires that inversion of thinking we mentioned. Don't just ask, what does this nerve do? Ask, given these symptoms, this pattern of numbness, dermatome, or weakness, myotome, which nerve, root, or pathway must be affected?
And related to that, think about the silent forces. If paralysis knocks out one set of muscles,
the limb doesn't just go limp. It often assumes a characteristic abnormal posture. Why? Because of the remaining unopposed tonic contraction of the healthy antagonist muscles. That posture is a direct, visible consequence of the loss of balance in that subtle, continuous background tension that maintains normal joint position. Understanding that underlying tone is pure clinical anatomy in action.
a really powerful point to end on. The body is never truly static.
Never.
Okay, that wraps up this deep dive. Join us next time as we continue our exploration of Moore's clinically oriented anatomy.